Welcome to the deep dive, where we take complex source material and turn it into actionable, fascinating knowledge. Today, we are focusing on a condition that affects millions, yet it often gets mislabeled as, simple allergies or maybe chronic dry eye. We're talking about ocular rosacea. Our mission is to quickly unpack this chronic inflammatory eye condition. We need to figure out its surprising connection to the skin, pinpoint the aggressive triggers that cause flare-ups, and really lay out the dedicated, multifaceted treatment roadmap you need to manage it effectively.
Yeah, and it's such an important deep dive because ocular rosacea is essentially this chronic inflammatory cycle that targets the eyes and eyelids. And while it's strongly associated with facial rosacea, it causes these really distinct symptoms like redness, intense irritation, and that constant aggravating gritty sensation.
Like sand in your eye.
Exactly, like sand in your eye. And the stakes are high. I mean, if that inflammation goes unchecked, especially in severe cases, it can lead to some serious complications, including, permanent damage to the cornea.
Okay, so let's unpack this a bit. When we say rosacea, I think most people immediately visualize redness on the cheeks or the nose. They think of a skin problem, first and foremost. How often are the eyes actually involved? And what really surprised me in the source material was the timeline. Which one usually shows up first?
It's incredibly common, far more than people realize. National Rosacea Society surveys indicate that those early eye symptoms, that irritation and watery appearance, can affect up to 60% of rosacea patients.
60%, wow.
Yeah. And this is the vital insight. The eye symptoms can be the very first warning sign. They often appear months or even years before any redness shows up on the face.
That's a huge diagnostic challenge right there. So for years, you might be treating yourself for seasonal allergies or, digital eye strain.
Exactly.
When you actually have a chronic inflammatory disease starting in your eyes. So how exactly does the experience of ocular rosacea differ from, say, just flushing on the face?
Well, the difference is primarily in the affected tissue. So when rosacea targets the skin, we see that persistent redness, flushing, visible broken blood vessels, and sometimes inflammatory bumps. The eye version, though, it specifically targets the ocular surface and the eyelid structures. So instead of bumps on your cheek, you're dealing with the consequences of chronic irritation. And that manifests as extreme dryness, that constant feeling of having a foreign object like an eyelash in your eye, burning or stinging, and significant light sensitivity.
Photophobia.
Photophobia, that's the one. These are physical symptoms of inflammation that just go way beyond aesthetics.
Right. It's the difference between looking uncomfortable and actively being uncomfortable pretty much all the time. If 60% of people have these sort of vague early eye symptoms, we're missing a huge population who would benefit from early intervention.
We are. And that's because chronic dry eye syndrome itself is much more common and has so many other causes. So if a patient only presents with irritation and redness without the classic facial flushing, doctors often follow the standard path of just treating dryness first.
Makes sense.
But the expert guidance is pretty clear. When conventional dry eye treatments fail, or when the symptoms include that really distinct burning, gritty sensation, ocular rosacea has to move higher up the diagnostic list. It's about recognizing the whole inflammatory picture.
All right, that brings us to the core issue then, the underlying mechanism. If this is all driven by chronic inflammation, what are the primary ingredients that combine to cause this in the first place? What's the complex why?
Researchers agree there are basically four main factors creating this perfect inflammatory storm. First, there's a strong genetic predisposition. If you have family members with rosacea, your risk is just significantly higher. Second, and this is crucial, is immune system dysfunction. Your innate immune response, which is your body's rapid defense system, it sort of becomes overactive.
It goes haywire.
It goes haywire, exactly. It starts generating inflammatory compounds around the eyes even when there isn't a real threat, which leads to those persistent symptoms.
Okay, that explains the chronic nature, but what about the redness itself? Where does that come from?
That's number 3, vascular instability. The blood vessels in the skin and around the eyes, they just don't regulate properly. They undergo abnormal dilation. They expand way too easily. And they also develop increased vascular permeability.
So they get leaky.
Think of it like that, yes. The tiny blood vessels become leakier than they should be. That causes fluid to escape into the surrounding tissues, which creates that persistent redness and contributes to eyelid swelling. It's a physical consequence of the inflammatory damage.
That's a great explanation. So it's not just surface redness. The inflammation itself is causing a kind of structural breakdown of the blood vessels, forcing fluid out.
Precisely. And the fourth factor is the increasingly studied role of Microbial factors.
Yep.
This includes the overgrowth of Demodex mites on the skin and eyelids, which can trigger inflammatory reactions. And then there's a potential, though I should say it's still debated, link to gastrointestinal bacteria, specifically Helicobacter pylori.
Wait a minute. The same bacteria that's implicated in stomach ulcers might be connected to my red, irritated eyes. Now, that's where it gets really interesting. So is it fair to say that if someone suspects ocular rosacea, they should also get screened for H. pylori? Or is that still more of a theoretical link?
You know, the link is strong enough that it warrants clinical consideration, especially in difficult-to-treat cases. It suggests that systemic inflammation, maybe driven by imbalances in the gut microbiome, can manifest in seemingly unrelated areas.
Like the eyes.
Like the eyes.
Huh.
It really underscores that rosacea is a whole-body disease, not just some localized skin issue.
That leads perfectly into external triggers. Because while those internal factors set the stage, it's environmental and lifestyle choices that really send the system into a flare-up. What did the American Health and Drug Benefit sources highlight as the biggest culprits?
The statistics are pretty compelling, and they show how unavoidable some of these are. Sun exposure is number one, affecting 81% of patients.
81%, that's huge.
It is. Close behind are emotional stress at 79% and hot weather at 75%. And even, common physical things like wind, heavy exercise, and alcohol consumption are major contributors.
So basically, going outside on a sunny, windy day after a stressful workout could be a guaranteed flare-up cocktail.
It really could be.
That's a huge, overwhelming list for someone to try and track personally. How do you advise someone to actually zero in on their personal culprits without just avoiding life altogether?
That's the key, right?
No.
Trigger avoidance has to be personalized. We advise keeping a detailed journal. Track not just what you eat, but the intensity of sun exposure, your stress levels, and crucially, how long after the exposure the symptoms flared. It turns that big list into a personal map. And we also need to be specific about diet. It's not just spicy foods or alcohol.
Right.
Specific chemical compounds are often triggers. Histamine-rich foods like aged cheese, wine, processed meats are known issues. And surprisingly, foods containing something called cinnamaldehyde, which is in common things like tomatoes, citrus fruits, and chocolate, can also be major contributors for some people.
That just highlights the detective work required. You're not just avoiding obvious irritants. You're looking for specific chemical pathways that are causing those blood vessels to destabilize.
Okay, let's turn to the complications. We know it's chronic inflammation driving these issues. What are the actual long-term structural changes we need to worry about in the eye itself beyond just temporary irritation?
The eyelids are where you see a lot of significant damage. You get chronic eyelid redness and swelling, scaling, and crusting. But the most important structural issue is something called meibomian-gland dysfunction, or AGD.
MGD, okay.
What is that?
So the meibomian glands are these tiny oil glands in your eyelids. They secrete the lipid layer of your tears. That's the layer that stops your tears from evaporating too quickly. Rosacea inflammation causes these glands to become blocked, and the oil they produce gets really thick and viscous.
So it can't get out.
It can't get out.
Yeah.
And the result is chronic, severe, dry eye because your tears just evaporate instantly.
That explains the constant dryness that, artificial tears can't seem to fix completely. It's not just a lack of water.
It's a failure of the oil seal.
It's the oil seal, right?
Exactly. MGD is the root of the problem, and this chronic inflammation on the eyelid edges is also known as blepharitis. The blockages also dramatically increase your risk of painful styes or chalasia.
But what about actual vision? We mentioned corneal damage earlier. How severe can that complication get?
Vision impairment is, thankfully, rare, but when it happens, it's serious. It's primarily caused by keratitis, which is inflammation of the cornea, the clear front part of the eye. Severe, recurrent episodes of this rosacea-related keratitis can lead to corneal thinning, opacities, and even ulcers.
Ulcers on your eye?
Yes, and in the most extreme cases, and again, this is rare, maybe in about 5% of patients with corneal disease, those ulcers can perforate the eye, leading to severe vision loss or even blindness. The inflammation doesn't just feel bad. It can physically compromise the structure of the eyeball.
This raises a really important question. Since this involves redness and scaling, it seems like it could easily be confused with other conditions. What are the main lookalikes?
Misdiagnosis is very common. Ocular rosacea is often confused with atopic dermatitis or seborrheic dermatitis of the eyelids.
They all look pretty similar, I imagine.
They do. They all share symptoms like redness, scaling, general discomfort. In fact, many rosacea patients have a coexisting condition like seborrheic dermatitis. The crucial difference, though, it comes down to treatment. Seborrheic dermatitis is often linked to a fungal component and needs antifungal treatments. Rosacea, on the other hand, is purely an inflammatory disease. It needs dedicated anti-inflammatory approaches.
So you could be using the wrong treatment for years.
Potentially, yes. A doctor has to look for that full constellation of symptoms, like the flushing history and that distinct gritty sensation, to be sure.
Okay, so given that this is a chronic disease, treatment is really about management, reducing flare-ups and daily discomfort. What are the essential first-line things that a listener should be doing right now?
Management always starts with heat and hygiene to tackle that MGD. Warm compresses are the absolute gold standard first-line approach.
Just a warm washcloth.
A warm, moist washcloth or a dedicated eye mask, yep. You apply that gentle heat for 5 to 10 minutes, ideally twice a day. The goal is just to liquefy that thick, blocked oil in the gland so it can flow properly.
Right, get things moving again.
That thing's moving. And that has to be paired with dedicated eyelid hygiene. Gentle cleaning along the lash line with a mild pH-balanced cleanser helps remove all that inflammatory debris, the crusts, and those Demodex mites we mentioned. For basic comfort, artificial tears are essential. I think the stat was 72% of patients rely on them. And for systemic support, omega-3 fatty acids are often recommended for their anti-inflammatory effects.
That covers the hygiene and comfort side. But what happens when that foundational daily care just isn't enough to break the cycle? What's next in the medical arsenal?
That's when we bring in prescription treatments aimed at suppressing that localized immune response. For topical use, we turn to immunomodulators.
What are those?
They're drugs like cyclosporine, which helps your body produce more of its own tears, or tacrolimus ointment, which directly suppresses the overactive immune cells in the skin. We also use certain antibiotic eye drops like azithromycin, which actually improve the quality of that lipid layer. And for severe inflammation, or if the cornea is involved, we move to oral anti-inflammatories. Low-dose oral antibiotics, especially doxycycline, are crucial here.
But not for killing bacteria.
Not for killing bacteria, no. They're used for their powerful anti-inflammatory effects throughout the body. In the most severe cases, oral retinoids like isotretinoin might be used. But a key note of caution, we try to avoid long-term use of steroid drops because they can significantly increase eye pressure.
Okay, so before we wrap, let's connect this back to skincare. Since the skin around the eyes is ground zero for this inflammation, what gentle ingredients should people be looking for to support that damaged barrier?
When inflammation is raging, the skin barrier is always compromised. It gets dry, it's vulnerable. So skincare has to focus on repair and hydration. You want gentle emollients that restore structure. Ingredients like fatty alcohols, things like cetyl alcohol or stearyl alcohol, are essential.
And those aren't the drying kind of alcohols.
No, not at all. They are moisturizing agents that prevent water loss and reinforce the barrier. And of course, hyaluronic acid is fantastic. It attracts and binds massive amounts of moisture to the skin, which hydrates deeply and helps calm the inflammation that follows a flare-up. You're actively helping the skin heal itself.
This has been incredibly enlightening. So to summarize the core takeaways for you listening, ocular rosacea is far more than just red eyes or cosmetic flushing. It is a chronic inflammatory disorder. It's driven by internal issues, your genetics, your immune system, and highly reactive blood vessels. It demands a really sophisticated multi-step management plan that involves daily dedication to hygiene, personalized trigger tracking, and often medical anti-inflammatory help.
And remember that crucial diagnostic distinction. Because it's so easily confused with look-alike conditions like seborrheic dermatitis, you have to insist on a diagnosis that confirms the inflammatory root cause. That's the only way to ensure you get the right treatment to protect your long-term eye health.
And for a final thought, considering the strong link we identified between systemic factors, specifically that potential overgrowth of gastrointestinal bacteria like H. pylori and the overall condition, how might treating your underlying gut health and microbiome imbalance be the single most overlooked and maybe most proactive step you could take in managing the chronic inflammation around your eyes? Go explore that connection.